Good morning. Welcome to a session under the banner of Clinical Epidemiology series, short course in clinical epidemiology. So as you have been aware, we have been doing critical appraisal sessions covering various aspects of diagnostic accuracy studies. We have had sensitivity, specificity, diagnostic systematic reviews. We have had ROC curves. So as a continuation, today we wanted to focus on agreement statistics, reliability, Kappa Statistics, ICC. So it's our pleasure to welcome Dr. Vineeth, consultant in general medicine, who will be critically appraising diagnostic accuracy study, but he'll be primarily focusing on reliability in this session. Once again, as always, we request online participants to post their questions in their chat box, or if you have questions, you are free to unmute and ask your questions at the end of the session. Once again, welcome. I'll hand over to Dr. Vineeth.
Good morning, everyone. Today, I just wanted to start with a case. So we have this 42-year-old lady who comes with 2-year history of Zika symptoms, fatigue, and joint pain. And she's got recurrent parotid fullness. She's got dry eyes and mouth, small joint arthralgia, and parotid enlargement, all her complaints. But examination, although the parotid gland was enlarged and firm, Schirmer's test was normal. ANA was positive, but anti-SSA and Rho were equivocal. And she's had a salivary gland ultrasound done previously, which was completely declared to be normal. Now, the thing is, for the diagnosis of Sjogren's syndrome, we need Zika symptoms, which are objectively demonstrated, as well as evidence of underlying autoimmunity. In this patient, the autoimmune spectrum is not very clear, and Schirmer's is normal. There's no objective evidence. So the question is whether we can use this imaging to further guide any decision making in this patient. So we'll be appraising this study, the reliability of color Doppler ultrasound of the major salivary glands in Sjogren's disease, using the CASP checklist. So coming to whether the study addressed a clearly formulated research question. So the patients were clinically suspected of Sjogren's disease. This was done in the Netherlands in a tertiary care specialist Sjogren's center. So they presented with Zika symptoms, which are the glandular features, or fatigue and arthralgia and other extraglandular features. And all of them were planned to undergo salivary gland ultrasound. So they looked at the interpretation of these images done by a resident and a trainee, a resident with some training and a trainee with very minimal training, compared to the interpretation by 2 experienced sonographers. And the outcomes they were looking at is both intra and inter-observer reliability of the color Doppler ultrasound of the major salivary glands. So was there a comparison with an appropriate reference standard? It was compared to the scan done by actually a pair of expert radiologists. So 2 of them did the scans independently, and that was the reference standard to which it was compared to. So did all patients get the diagnostic and the reference standard? Yes. All patients were scored by all observers in this thing. Could the results of the test have been influenced by the results of the reference standard? Now, the images were scored independently. Actually, they were scored twice. Once at the time of presentation, once more the images were reviewed 2 weeks later. They were scored independently by all 4 observers. So initially it is there. The second time also they have not explicitly mentioned it, but because it was a random sequence of images that they were shown, it is likely that it was unlikely that it has been influenced previously. So coming to what score they use, this is the OMERAC score that has actually been validated in Sjogren's. And this is to look at salivary gland involvement, and based on the scores. So all these sonographers, including the trainee, were given written instructions and trained on 10 patients as to how to score these patients prior to the answer. So is the disease status of the tested population clearly described? So coming to the actual baseline characteristics, actually most of their patients were middle-aged women, which is the same demographic of Sjogren's seen worldwide. And the Hosiva score is the precursor of the OMERAC score on which it's based. The final clinical diagnosis, 75 of these patients ended up having Sjogren's syndrome proven, and 25 were Sjogren's disease. 75 were Zika patients, and 25 were non-Zika Sjogren's disease patients. And further, all the characteristics were also fitting in with the general population. Now, why that's important is actually in a diagnostic study, the spectrum bias is what we're looking at. Whether this particular subset of patients was different from the general population of patients with Sjogren's disease, and so whether this could influence those outcomes. But by and large, it is findings that are common to generalizable population of patients with Sjogren's disease. So were the methods for performing the test described in sufficient detail? So they've described in great detail the probe use, the position of the patient, the depth of the depth of the scan that they did, and they were also all patients were instructed not to consume any water or fluids 1 hour prior to the ultrasonographic evaluation. Now, even how they scored the images, basically all of them received written instructions on how to score, and 100 consecutive patients were scored independently. So they took all the images, made a PowerPoint, and then showed it in random order independently to all 4 observers, and then asked them to score the patients. So did they have enough participants to minimize the play of chance? They have not described the sample size calculation in detail. They've just said that they've taken 100 patients. So how have the results been reported? Results have been reported using intra-observer variability with the weighted Cohen's kappa and the Fleece kappa, and the intra-class correlation coefficients for inter-observer variability. Now, how do we interpret these findings? That's the how do we interpret these tests? So the basic talk for today is on tests of reliability. How to decide if inter or intra-observer variability is significant or not statistically. So we look at 4 main questions. We want to know what is reliability first of all. Then we want to know about concordance between 2 observers, whether it's, and what its limitations are, why we need these tests, and how to calculate these tests. Okay, I'm sure we are all familiar with this. So the truth is actually, the accuracy is how far away from the truth we are, and precision is how close the values align with each other. So tests can be low accuracy, low precision, all the way to high accuracy, high precision. Now, this is not exactly what reliability is. So can anyone tell me which is the longest line in this room? Option A, B, or C? All are the same, concurred by everybody here. Okay. So if you go on to see this, yes, all are the same size. But because of this visual illusion, by it looks like B is the longest line mostly. Okay, so almost everyone here concurred that all lines are the same length. But suppose that majority of them actually said that B was the longest line, there'll be good concordance. Everybody here will agree, but it's not necessarily the truth. However, once you know that all are the same lines, again, the concordance will be good that all are the same size, and that is the truth. So what I'm trying to say is that the same observer using the same instrument, if they keep on generating the same result, that's called repeatability. Whereas if a different observer with the same instrument or the same observer with a different instrument can repeat the same result, that's called reproducibility. These 2 things are together called reliability. Now, reliability doesn't guarantee accuracy. If an instrument is giving, say, 2 kgs extra weight for everyone, it will always keep on showing 2 kgs extra weight. That doesn't necessarily say that it's telling you the truth, but it does tell you that if you keep on repeating the experiment, you will get the same value. So the problem is the converse is true. If a test is unreliable, it cannot be accurate, because at some point of time, it will keep on giving different values. So that is why reliability is very, very important to use in a diagnostic test. So coming to what is concordance. Now, let's use an example. Suppose we're using a depression rating score, and that is done by everyone sitting here. And so based on that score, you've classified the patients as depressed and non-depressed. So 2 independent clinicians are using the score to score. So if that is the numbers that they got, so the first rater has shown that 40 patients are depressed, 40 are not depressed and 30 are depressed, and similarly, and so on and so forth. So can anyone here tell us what is the concordance between these people? For those who came, I'll just briefly repeat. We're using a score to look at whether patients are depressed or not. So 2 independent clinicians have used the score to grade whether patients are depressed or not. So the question is, with those numbers over there, so for example, rater 1 has shown that 40 plus 30, 70 patients are not depressed according to them, and 130 patients are depressed. But if you go vertically, rater number 2 has shown that 40 plus 20, 60 patients are not depressed, and 30 plus 110, 140 patients are depressed. So can anyone tell me how much is the concordance? How much do they agree on? 150. Correct. So how did we reach that number? Okay. So basically, this 40 over here in the top right corner is where both the raters agree that the patients are depressed. And similarly, the bottom right corner, the 110, is when both agree again that both the patients are depressed. Okay, so together in that diagonal is where we get the concordance, where both the reporters agree that the patients are either depressed or not depressed. So 40 plus 110 is 150 out of 200, which gives you a concordance of 75%. Okay, so now that we have understood how to use this, let's try another example. Anybody wants to say the concordance in this same scale? Two other people have used it for 200 patients. How did we get 95%? So basically, again, we see that 190 patients both agree are not depressed and 0 patients both agree are depressed. So together 190 out of 200, which is 95%. Can anyone tell me what is the problem with that conclusion? If you actually see where they disagree, rater number 1 has said 5 patients are depressed. Rater number 2 has also said 5 patients are depressed, but none of those patients overlap. So two completely separate set of patients are depressed according to both of them. But the concordance seems to show that both are in very close agreement. So this is the problem with just using concordance to look at inter-observer variability. Okay, if the proportion is high anywhere, then everywhere else the concordance looks very good artificially, even though they actually have not agreed on anyone. The purpose of the scale was to search for depression. Nobody has agreed on who's depressed, but the concordance is very high. So that is where we use these tests of reliability actually. So we use this kappa test, Cohen's kappa for two nominal variables. We use Fleece kappa for more than two nominal, and we use interclass for continuous variables, interclass coefficients, correlation coefficients. So we look at how these are derived and what it means. So again, one more example. Can anyone tell me what is the agreement in this set? Same example, same this thing. How much do these two raters agree now using these numbers? 36 out of 50. It's the same as the concordance. That's how much they agree. Okay. So they both agree that 36 out of 50 patients, they are in agreement whether they're depressed or not. Okay. That is the concordance. Now, how do we calculate the probability that these two people agreed by chance? Okay, that is the question we need to answer to calculate kappa. So how do we do that? That's something we can use something called sampling without replacement. Okay, so for example, a jelly bean technique. Suppose these two radiologists, these two people using the depression score never looked at any patient, never used the score. They just had a set of jelly beans given to them as a total number, and they had exactly. So how many patients did rater number 1 say are not depressed? 17 plus 8, which is 25 out of 50. So imagine they had 25 green and 25 red jelly beans in that jar. So by pure chance, they just picked up a jelly bean. If it was green, they said not depressed. If it was red, they said depressed. That is a probability that rater number 1 has said these 25 patients by pure chance. Okay. And similarly, rater number 2, if you looked on the vertical, that is the probability that they said it by chance. So how do we now interpret this into this thing? So that first 25 out of 50, which is called the marginal of rater number 1, is the probability that rater number 1 said these patients are not depressed by pure chance. Okay, without using anything. That's that first 25 by 50. Now, when we look at the next, what is the probability that rater number 2 also said these patients are not depressed by pure chance? That is 23 out of 50 by pure chance without looking at anything. So if you multiply the two, you'll get the probability that both of them said that by pure chance. Okay, that will give the concordance for the not depressed patients by pure chance. Now, if you go on to look at the same thing, patients who are depressed, what is the probability that rater number 1 said these patients are depressed by pure chance? Okay, that will be 25 out of 50. What's the probability that rater number 2 said these patients are depressed purely by chance? Again, this is 27 out of 50. So if you multiply those two, you'll get the probability that these two said that they are depressed purely by chance and not by anything else. So if you add those two, you get 0.5. Okay. So now coming to the formula for Cohen's kappa. Okay, that is the observed probability minus the estimated divided by 1 minus the estimated probability. So if you apply this into the formula, you will get 0.44. Okay. Now, how do we interpret that? If you have a value of between 0 to 2, you will say it's fair agreement. If you say 0 to 4, it's moderate. If it's 0 to 6, it's substantial. And if it's 0 to 8, it's about, it's more than 0.8, it is almost perfect agreement. Sorry, it's not 0, it's 0.2, 0.4, 0.6, and 0.8. Okay. So how do we actually understand this formula? What is it actually telling us? Okay, if you see the numerator, what is this term? This is the observed agreement. Okay, and that is the estimated agreement. Now, what does subtracting those two tell you? That tells you how much more than the estimate the observed is. Correct? I'll give you an example. Look at that diagram at the bottom. Okay, the observed estimate is 90%. And the estimated by pure chance was 60%. Okay, so therefore, how much better is 90% than 60%? That's what that numerator is telling you. Okay, which is 30% better. Now come down to the denominator. If it was perfect, they had perfect agreement, the agreement will be 1 or 100%. Okay, and the estimate difference will be 60 to 100 will be 40% difference between those two. So if you actually do that, you're trying to say that the difference between the observed and the estimated versus perfect and the estimate. That fraction is what is actually kappa. Okay, so just by looking at that arrow, you can tell what the kappa is. It's 75% because the upper arrow is 75%. So how can we apply that? Let's just use an example. If the observed is 50% and the estimated is 10%, what will the kappa be? 40 by 90, which will come to 0.44. Okay, so that's actually what kappa is telling you. It's telling you between the observed and estimate versus between perfect and estimate, how much is the ratio. So that's what Cohen's kappa tells us. Now, Cohen's kappa is very good if you have two observers with a dichotomous variable. Okay. How do we use it if we have more than two categories? Okay. How can we apply the same statistics if we have more than two categories? Now, can anyone tell me what are all the possibilities here? Okay. Where are the two in perfect agreement? If you actually see, if you look at the diagonal there, 1, 1, 1, that is when all the observers are in perfect agreement. Now, how many other possibilities are there? If you look at the opposite diagonal on the top right and the bottom left, that is when they're in complete disagreement. Correct? But what about in between? They're in partial agreement. Correct? Are you guys understanding what I'm trying to say? So on that diagonal there, from the top right to the bottom left, they're in perfect agreement. The opposite diagonal is when they disagree completely. But in between is when they are partial agreement. So with this, we use something called the weighted kappa. We say that when they're in complete agreement, we give full weightage. We multiply it by 1. Okay. When they're in complete disagreement, we give 0 weightage. And when they're in partial agreement, we give half the weightage, which is we multiply that probability by half. So adding up all this is how we use a weighted kappa to interpret. The interpretation is the same as normal kappa, but this is used when there are more than 3 categories of dichotomous variables. Okay. Now, this is something called the Fleece kappa. What is the difference? The advantage we have is these are dichotomous variables. They're just yes or no answers. So now you look, there are 7 patients in this depression scale, and there are 3 different raters sitting there. The same scale as what we used earlier. So how can we now check the agreement between all these people? We then add up all these. So for example, for patient number 1, how many raters felt that they were not depressed? 0. And all 3 felt that they were depressed. So we convert it like that. And so if you go down and take all the summation like that and then apply it into the formula, I'm not going into the derivation, but this is actually how we derive Fleece kappa. Okay, when you have dichotomous variables, but more than 2 categories to look at. Okay. So weightage is when you're actually attributing for partial agreement. Okay, but in this, there is no partial agreement. It's a pure dichotomy. Yes. Raters also. So yeah, that is for the observed, and for the estimate, again, we use another formula and we apply the same thing using the same summation there. And so we finally we apply it into the same formula and get the fleece kappa for this population. Again, the same way we interpret the fleece kappa. 0.2 is fair, 0.4 is moderate, 0.6 is substantial, and 0.8 is almost perfect agreement between the observers. Now, what is the problem? If you have continuous variables, you can't use any of these. Okay, because these are all for dichotomous variables. So how do we interpret if we have a continuous variable? For that, we need to understand what this variation is when there are continuous variables. Let's take an example. Suppose you have 5 companies, okay, and that's what on the x-axis, and on the y-axis you have the profitability. Okay, if you actually look, this is a box and whisker plot. So it's showing you that within, say, company 1 itself, there is significant variation. Similarly, company 2 also has variation, company 3, 4, and 5 each have their own intra-company variation. Plus, there is variation between the two companies. So, inter-company variation is also there. Okay. Now, our question is, how do we use this to measure? So, we calculate something called the intra-class or the interclass correlation coefficient based on what we're looking at. So, the sigma square of B is the variance between groups, and sigma square of W is the variance within the group. So we're trying to isolate the variance and say that this is interclass, suppose we're looking at, it's only the variation that is between the groups compared to the total variation due to a summation of these two. Okay, we're trying to isolate that this much variation is because of the difference between the different companies. And the other segment of that variation is due to the intra-company variation. When we compare the two, we get this intra-class correlation coefficient. Okay, so this is what we use for continuous variables. Now, coming back to our study, we will now use these three things. We looked at kappa, we looked at fleece and Cohen's kappa, and we also looked at weighted kappa and intra-class correlation coefficient to look at our study and interpret the results of the study. So now if you actually see the intra-observer weighted Cohen's kappa. Intra-observer means there were 4 total observers who looked at the ultrasound scans of the patients. 2 were experienced sonologists, 1 was a trainee and 1 was a resident. If you see them, the inexperienced observer had an intra-observer kappa of 0.23. So how do we interpret that? That means that there was very little correlation between what you said the first time and the second time. Okay, looking at the same image. But if you see for the experienced observer, it was 0.81. Both the times they were quite in agreement with what they felt the scan showed. Now, if you go to the intra-class correlation coefficients for intra-observer and for inter-observer variabilities, you actually see that it's 0.53 for an inexperienced observer, again low, and 0.9 for an experienced observer. Okay. So, and similarly, you go to the static and live images. So, we'll go through this in detail. How do we interpret? So, how sure are we about the results? They've also described the confidence intervals of these results. So if we just look at how they've actually looked at it, this is the left submandibular gland, left parotid, right submandibular, right parotid. They looked at observer 1, 2, 3, 4, and they added up all the grades of these observers. Okay, and then they got the total score. Then what did they do with that score? This is how they looked at the intra-observer variability. So for, say for example, observer number 1, okay, the left submandibular gland. What did they do? They looked at how this observer interpreted the scan on day 1. And the same images when they were shown to him 2 weeks later, how he interpreted that scan. That is what they've calculated the weighted Cohen's kappa for, and that's come to 0.76. Because he's a experienced observer. If you actually go down to observer 2, it's 0.7. Again, another experienced observer. If you go down to the trainee seeing the thing 2 weeks apart has a weighted Cohen's kappa of 0.67. Okay, and if you see the observer number 4, that's a resident. The trainee who's observer number 4 actually has a weighted Cohen's kappa of just 0.43. So showing the same images 2 weeks apart, their interpretation was different. Okay, similarly, for each of the 4 glands, they've actually gone on to see. Now, how do they look at inter-observer variability? Okay, now inter-observer variability is they have to first compare pairs. Okay, so that's what they've done, say for observer 1 versus 2. Okay, if you actually look at the second row, the observer 1 versus 2, they calculated the weighted Cohen's kappa for one particular scan. So 0.55 was the agreement between the two. But if you see above that, 0.46 is the fleece kappa that they have got for all of them together. Because these are all just dichotomous pairs, so they can still use fleece kappa. Okay. But when it comes to the total CD score, that is a continuous variable. So what have they used for that? They've used the intra-class correlation coefficient to interpret that score. So similar, so this was all done for session 1, which was done at the very beginning. Then they didn't repeat the scan, they showed the same images a second time to the same 4 set of observers, and then they looked at how they interpreted them later. Okay, so they've done what all they've done for each observer, intra-observer variability 2 weeks apart for the same images. Then they did pairs of all the observers, and then they've also looked at it, the same set paired 2 weeks later, and seen all the combinations and seen how they actually interpret these scans. So coming to, can this be applied to our patients or the population of interest? Okay, because we looked at the baseline characteristics of this population, they're mostly middle-aged women, and most of the characteristics are similar to the Sjogren's patients that we see also. So they can be applied to this thing. So were all the outcomes important to the individual or population considered? Yes, the results of the test can change management, because in our patients we didn't have conclusive evidence of gland involvement. But if this test can show that the gland is significantly involved, we can use it for our test. Can it be applied to our, so in our population, USG is cheap and it's increasingly available in India. But what this study shows is actually that the trainee and the resident are not able to interpret the scan as well as a trained observer. So we will need specialized training to use the scan. So what would the impact be? Sjogren's, we know, has no diagnostic test. There's no gold standard diagnostic test. So this will provide a valuable new tool to potentially diagnose Sjogren's patients in clinically suspected patients. Okay, may not work as a screening tool in the general population, but in clinically suspected patients. So coming to the summary of our appraisal, there was a clear PICO statement. It was a correct study design. There was appropriate recruitment, objective measures, and data collection. But they have not clearly specified their exclusion criteria. They have not talked about the blinding, and they've not for the second set of scans. In the first set, they said they 4 independently reviewed. We don't know in the intervening period of 2 weeks whether they could see. And the sample size calculation was not described in detail. So coming back to our case, what are the options we have? So if this patient came to you on a Saturday OPD, we have one option is to get the weekend ultrasound done by the on-call radiologist, who may be a resident or a trainee if they're a very junior trainee. Or we wait, maybe sometimes we need a senior radiologist, so it may take after the Christmas vacation. Or should we consider doing a new study in our population to look at these outcomes? What does everyone think? So based on this study, I would like to conclude that I would like to redo the scan. We don't know who did the scan outside. I would like to get it redone by a senior radiologist if possible, and see if that will give us any additional information about the gland involvement. Thank you.